Today, let's talk about pressure injectors, and we're going to go through some parameters. Now, the parameters I'm going to talk about, please do not memorize them. Uh, each facility will have their own protocol, and it can even change physician to physician. So it's mostly to give you an idea of what kind of flow rates and um, volumes that should be delivered. Okay, introduction. Without pressure injectors and contrast media, angiography would be virtually impossible today. This lecture will discuss proper pressure injector use along with contrast media selection and use. For our objectives, upon completion of this lecture, the student should be able to, number one, state the purposes of a pressure injector use, explain various settings of the pressure injector, recall catheter recoil and whip. I will have a demonstration for you uh, uh, later this week. And then you should be able to safely use a pressure injector. The purposes for pressure injector use. Okay, there are three main purposes for using pressure injectors. First is to administer a precise bolus volume. In other words, we want to be very exact about it and for specific vessels. It's for a rapid bolus injection. When we're using this for rapid bolus injection, this is going to be used in the like the left ventricle, the aorta, the inferior vena cava, uh, and we have to inject such a high volume at a high pressure that you cannot do it with your bare hands. And then precise flow rate for delivery of TPA or other thrombolytics. We can set this to where it will give exactly the flow rate that's needed. So the three reasons you use a pressure injector are to administer a precise bolus volume, to do a rapid bolus injection, and to have a precise flow rate. Let's go through some formal things about pressure injectors. They're primarily used in CT, the vascular interventional suite, and the cardiac interventional suite. They come with large disposable syringes that are placed in a sleeve. The sleeves are about, the thickness of the walls is about, almost a half an inch. And the sleeves and the syringes come in various sizes, anywhere from 60 cc's to 200 cc's. Some syringes will come preloaded with contrast media. It's the preset parameters that will control the injection. In other words, you will see here in just a moment that you're going to set a flow rate, a volume, a pressure, a rate of rise, and that will determine the injection. And then this is going to be started up with the depression of a hand or foot switch, or it can actually interface with your imaging equipment so that it's just part of the system there. If it's a hand or foot switch, it is a dead man switch. In other words, if you let up on the button, the injection will terminate at that time. And here's some pictures. Picture A, that's a ceiling mounted pressure injector. And it's the same head as what you see in the next image over. See, this is the injector head. Here's the injector head here. This is what you'd see a lot of times in a cardiac catheterization lab. You'll see one like this sometimes in CT, and then you'll also see the injector head mounted to the table in a vascular interventional lab. And you can see the thick plastic walls This is the sleeve here, and then this is the syringe that would be put into the sleeve. So let's look at the control panel. You're going to see that we have several different settings that we must select. Okay, rise, fall. We don't want to go from 0 psi immediately to 900 psi. We want to ramp the pressure up. The reason we want to ramp the pressure up and ramp it back down is it will reduce catheter whip and catheter recoil. Catheter whip is kind of like you know, the water toy when you're a kid. It was a willy wiggle or a silly wiggle or something like that, and it would just fly all over the yard when it's hooked up to the garden hose. That would be catheter whip. Catheter recoil is going to be like if you go to the car wash, the coin-op car wash, and you turn on the high pressure water and you feel it pushing back at you. That would be the recoil. So we want this to ramp up slowly, and it's going to be like 0.2 seconds from 0 up to the selected pressure. The flow rate is going to be what is the volume delivered per second, per minute, or per hour. In the interventional suite and in the cardiac suite, you're going to see that we're doing injections of volume per second because we're doing large, fast, filling large spaces. If you go over into CT, you might see that it's going to be a volume delivered per second or per minute because it's usually going to be, if not always, going to be a venous injection. The volume is going to be the total volume of contrast to be delivered. So what I could do for a left ventriculogram is I could have a rise fall of 0.2 seconds, a flow rate of 20 cc's per second for a total volume of 40 cc's. Injection duration is going to be determined by the rise fall, by the flow rate, and the volume to be injected. In other words, you're usually not going to set injector duration. It is the result of the other selections. Pressure is going to be measured in pounds per square inch. Now, for a left ventriculogram, you might set it at 900 psi. So if we set it at 900 psi, it's what we're saying is that is the limit. And it's only going to put in the pressure that's needed to deliver the flow rate. In other words, if we're getting 20 cc's per second at 600 psi, it's not going to go any higher than that. And then we can do injection delay or X-ray delay in the timing. Here's a control panel of our unit that we have down in our simulation lab. Yes, it's from the 1970s, actually from the 90s. You can see here it's nice bright orange, and we'll go through and take a look at the panel. Okay, so here we have rise fall. What you do is select the delta, and this is going to start blinking right here, this little light. You would come over here and go 0.2, hit the delta again, and it sets it. Okay, over here, if we select the delta here, then we can change this 20 mLs per second to 10 mLs per second or 30 mLs per second. If we select this one, it's going to go from milliliters per second to milliliters per minute to milliliters per hour. Right here, this is the total volume to be delivered is 40 mLs. Remember, a milliliter and a cubic centimeter are interchangeable units. And then because of this selection that we have right here, the injection duration, it's telling us it's 2.1 seconds. And you would think 2 seconds with 20 mLs per second for a total of 40 mLs, but we have this rise fall. So it adds 1/10 of a second to it. And then finally we get to the pressure setting. This can be set anywhere from 1 up to, I want to say this unit will do 1200 psi. And that's kind of about the pressure that you would be using at a coin-op car wash, is 1200 to 1500 psi to spray off your car. Why do we need the high pressure? Well, you have to remember the lumen of the catheter is very small, and so you get a lot of friction in there, and so it takes a high pressure injection to get the flow rate that's desired. And then you can have an X-ray delay or a injector delay for specific exams. A perfect example in CT is we'd have an X-ray delay and then set it at, I don't know, 10 seconds. And then after 10 seconds of injection, then it starts to image. When you get ready to arm this, you select single, and it's going to then ask up here, have you expelled all the air out of the system? And you go yes, and that will arm the unit. Here's what you're more likely to see out in the field today. This is a touchscreen unit, and looks much more modern. But the essential workings of the pressure injector, they're the same. And here's another one. And what we have here is you have the contrast, and this is a dual head injector, and then you have saline. So what happens is if it's going to deliver, it looks like 20 mLs or cc's of contrast, and then it's going to be followed by a short injection of flush. And that's so that you can limit your contrast use and keep the patent IV port. So let's talk about safety features. We have a few safety features. First one is going to be pressure setting. You are going to get the information off of the catheter package as to what pressure would blow the tip off of the catheter. We have the rise fall, and this is to reduce catheter recoil and catheter whip. There is a mechanical stop that I'll show you here in just a moment, so that if the injector, the way that it injects forward is it's an auger screw, and it just screws the plunger pusher into the syringe. And so we have, in the event that for some reason it doesn't turn off, there's an actual metal block that will set for the volume of a volume of contrast that is to be injected. The syringe sleeves and the syringes themselves, they're clear plastic, and that's so you can visualize bubbles. The last thing you want to do is inject bubbles into the arterial system, because the surface tension of these bubbles will not allow them to break down smaller than 100 microns, and so you end up with air emboli. Now there are two other safety features that I don't have on here. The first one is that dead man switch. When you let up on the switch, it is going to terminate the injection. So Mason-Sones, the first coronary artery injection that was selective, it was because the catheter fell into the right coronary artery, and they initiated the injection and they could not stop it. So it injected 30 cc's of contrast directly into the right coronary artery. The other safety feature is that the injector is programmed to where it will not inject the last 10 cc's of the syringe. And the reason for this is when you get ready to make the injection, you're going to point the syringe or the injector head downward so that bubbles will go up next to the plunger. And it's not going to inject those last 10 cc's in the event that there is a bubble against the plunger. And here's what I was talking about. See this right here, this is the auger screw, and this is the screw that, or the nut that goes on that, and then this is going to be the plunger piston right here, and it pushes the syringe out. When you set a given volume, this is going to uh, uh, come up into place to where you will not deliver more than, let's say if you said, hey, it's going to be 40 cc's of contrast, you're not going to deliver more than that. Now remember, these parameters, don't get hung up on them. This is just to give you an idea. We're going to talk more about the anatomy as we go through here. But what we have here is that for carotid arteries, you want to have a total volume of 8 cc's of contrast media. Okay, the flow rate is going to be anywhere from 2 to 4 cc's. You're going to see as we get larger vessels, we're going to give a higher flow rate. The pressure is going to be set at no more than 300 psi. And then the image rate, this 2 for 4, this is two images a second for a total of 4 seconds. And then it's going to go to 1 per second for 6 more seconds. What we have here, this is the common carotid artery, the left common carotid artery, and then it's going to bifurcate. Okay, when it bifurcates, we're going to have the internal carotid artery here. The way you can tell is it is not going to have any bifurcations until it gets into the cranial vault. If you notice the external carotid artery, it bifurcates and it's going to be feeding the face and head. Here's a vertebral injection, vertebral artery, and you can see here you have the posterior and middle cerebral arteries. Now this is an interesting injection. This is an aortogram. This aortogram was done on a 12-year-old girl that was admitted into the hospital because she was having arterial hypertension. She had emboli to the lower extremities, and she had exertional dyspnea, in other words, shortness of breath. And what we have is a coarctation. In other words, if we take a look here, you can see the left ventricle. Here you can see the aortic valve, and you can see the aortic arch comes over, and then we have a stenotic region right here, real close to the left subclavian takeoff. And then after that, we have this big aneurysm here. What this is here, this aneurysm, is a post-stenotic aneurysm, and it's because of the turbulence that are produced by going through that narrowing. And so you get a post-stenotic aneurysm. So this is coarctation. See, it looks like it has 2 arches. And so what they did was they went in with an 18 millimeter Dacron graft and put it in here. You can see the graft right here. And her symptoms were alleviated. If you notice, the total volume is much higher here. It's 50 to 70 cc's, and a rate of 15 to 30 cc's per second, and the higher pressure, 600 psi. Here's an abdominal aorta. Now let's go through some of the anatomy here. So you can see the catheter here, right here, and they went in through the right femoral artery. This is digital subtraction angiography. If you notice, you don't see any spine behind here. You don't see any pelvis here. Okay, and so what do we have? We don't see the superior mesenteric artery, and we don't see the celiac trunk and the branches that come from it. But we do, they were really wanting to check out this. This is the right renal artery and the left renal artery. And then here you have lumbar arteries coming off. If we come on down, this is going to bifurcate into the right and left common iliac arteries. Then we have the left external and the left internal iliac arteries. Here's the celiac trunk. This is the celiac trunk injection right here. And here you can see the splenic artery going over this way. You can see it's hard to make out. In fact, you can't see it. This is going to be the common hepatic artery here. And then you're going to have the gastroduodenal and the hepatic artery proper. Then you have the left hepatic artery and the right hepatic artery. Here you have a splenic artery. This is kind of straight for a splenic artery. They're usually very tortuous. And here we have the hepatic arteries. So they've selected the common hepatic artery, and we have the hepatic artery proper after this bifurcation. You have the left hepatic artery, and here's the right hepatic artery. You have the gastroduodenal artery coming through here. And then the gastroepiploic. This is on the greater curvature of the stomach. You're going to have a right gastroepiploic and a left gastroepiploic that will anastomose on the outer curvature. Here we have a superior mesenteric artery. You can see here they picked it off, and this is an AP, and you can see all the branches here. This is going to feed the mesentery. This is also going to pick up nutrition from the digestive tract. And then here's a lateral. And so this is posterior here. This is anterior here. And they did the injection, and here you can see that superior mesenteric artery coming off here. Just superior to that superior mesenteric artery, you're going to have the celiac trunk. And you can see the left gastric artery. You can see the common hepatic, and you have the splenic coming towards you. Now this has been inverted. In other words, we turn black white and white to black, and so what you're seeing here is contrast media in the inferior mesenteric artery. You can see right here they have AVM, that's a arterial venous malformation. So the blood doesn't go across the capillary beds. It just goes to the arterioles, and then it goes into the venules. Here's a renal artery, and this is not a very good injection. See how the contrast is not opacifying the entire vessel here? We would call this laminar flow, and you want to do a better injection than that. You always want the contrast to come out into the aorta when you inject, so that you completely opacify the vessels. And here you can see the outline of the kidney, because that contrast is going out into the nephrons. Now this is an interesting study here. This is actually a bilateral runoff, lower extremity runoff, and this is actually an MRA, and we'll look at some different images here in just a moment. But this kind of shows you the whole thing: the abdominal aorta, the common iliacs, down the superficial femoral artery, and then you have your genicular arteries behind the knee in the popliteal region. When we do this in the VI suite, what's going to happen is uh, our flat panel detector is only 15 inches by 15 inches. So you start a long, slow injection, and you actually have a switch to where you can move the C-arm through move the table through the C-arm, and you just chase the contrast down the legs all the way to the feet. Pulmonary arteries. Here you can see this is a unilateral injection, and here again they just inverted this image, and this is going to be pulmonary arteries, but the contrast is showing up white. We didn't really care to do pulmonary work. Mast cells are in the pulmonary system, and that's where you get a big release of histamine. And so when you do an injection directly into the lungs, you have a higher likelihood of contrast allergic reaction. At the same time, you would think that an arterial injection would be more dangerous than a venous injection. But I would much rather do an aortogram on a patient than to do a inferior vena cavagram. And the reason is if you do that aortogram, the contrast is being diluted as it goes out into the entire system. And so when it comes back to the lungs, it's diluted. If we do an inferior vena cava, we have that big bolus of contrast that hits the lungs right away, and you have that higher risk of allergic reaction. We have the cardiac cath left ventriculogram. The image is down here. This is normal. See, this would be in diastolic volume here. You can see the pigtail catheter in that left ventricle. And here you see the contraction here. And we have a little bit of akinesis on the anterior wall right here. See that little bump right there? That didn't contract as well as it could. That should be down here like this. And then up here, this is an interesting phenomenon. This is the Takotsubo cardiomyopathy, or broken heart syndrome. This 90% of these cases occur in females between the age of 58 and 75 years of age. And most of them recover on their own, and with very little long-term damage. And you can see here the way this contracts. The base of the heart contracts, but the apex does not. And this is due to the causes this, and here's where we get broken heart syndrome, is if this female is under undue stress, or has had a loss in her life, something that's stressful or emotional for her. Now it's named after the Takotsubo octopus trap. See this Japanese octopus trap, and here you have the contraction of that left ventricle. Coronary arteries are going to be a hand injection, and it's going to be anywhere from 4 to 10 cc's, and you basically, we say 2 to 5 cc's per second, but in reality what you do is you take and do that injection until you see the contrast wash into the aorta, when you get that back wash. Here we have superficial femoral arteries. This would be the right, and this would be the left. You can see right here they have a radio opaque ruler, and that they've put in between the patient's legs, and what they're doing is estimating what length of stent do we need to fix this tight area. Now you don't fix these right here and right here. What you want to do is go from healthy tissue, so this is about 15 centimeters here, and come down here to healthy tissue, and now we're at 17 centimeters, so we need a 20 millimeter stent for the length of it. And here you can see this side is reasonably healthy in comparison. Now here we have an MRA of the lower extremity, and what you have is right up here, right going through the M and the R, this is where the inguinal ligament would be coming across. Superior to the inguinal ligament, the vessel is the external iliac artery. Once it goes through the inguinal canal, it becomes the common femoral artery. It will then bifurcate into the deep femoral artery, or the profunda femoris, and we're going to have the lateral circumflex artery coming off here. At this bifurcation from common femoral artery to the deep femoral, you're also going to have the superficial femoral artery that comes down. And then if you go on down, this is going to come down the anterior portion, then it dives into the leg, and right down here it comes through Hunter's Canal, and it goes down the back side of the knee, posterior to the knee. And over here you can see we have a lesion. Yeah, this is going to be a left SFA stenosis or lesion. And then here we have below the knee, right here, you're going to have the popliteal artery, right here, behind the knee. It's going to bifurcate into the anterior tibial artery. Anterior tibial artery is going to then become the dorsalis pedis, which we'll talk about later in the term. This bifurcation, this gives us the tibial peroneal trunk right here. Here is the peroneal artery, or it could be called the fibular artery right here. And then this is going to be the posterior tibial artery that is going to go down the medial aspect of the calf, and then circle around the medial malleolus into the foot. Don't worry about this one too much. I put this in here just to kind of show you what we do see out there. This vessel should be coming straight down here like so, but it's actually, we've gotten collateral flow. In other words, the patient has built their own bypasses to a certain extent. And that's it for today. I hope you enjoyed this, and have a good rest of the day.